First patient is a 43-year-old male status post fall with his left distal radius fracture. Of note, he had a prior distal radius fracture in May, did not follow up closely and settled with significant dorsal angulation prior to this fall. He also ambulates with bilateral forearm canes at baseline. The post-reduction films are on the right, and then his previous reduction films when he settled dorsally are on the left. So I was able to reduce him back to his previous angulation. Otherwise, he was neurovascularly intact, and we'll follow up in a week and have a discussion for surgical treatment depending upon his preference. This is a 14-year-old male status post fall with a right Salter Harris 2 distal radius fracture. He was neurovascularly intact, closed reduced, and placed into a sugar tongue splint. We'll follow up in the office.
Excuse me, I missed the last one. You said the last person's going for surgery?
No, if he had any preference to correct his dorsal angulation.
But it's healed already, right?
He rebroke through it.
Oh.
So he previously settled dorsally. He rebroke through it again. And then that was the reduction that I was able to get this time.
Is that the same as it was the first time?
No, originally he was.
Yes.
Oh, yes.
And what is it? What's the angle that it's pointing out dorsally?
What is that angle?
Yeah.
It's about 20 degrees.
So why couldn't you reduce it to the same as last time?
I did.
Oh, so if it was acceptable last time, why isn't it acceptable now?
It was not.
He lost reduction last time.
He lost reduction. He did not follow up closely. He lost reduction in his prior splints, and then he healed in dorsal angulation. He refractured through that, and then I was able to reduce him to his prior dorsal angulation state of which he healed into. So 15-year-old male status post fall with the left Salter Harris 2 distal radius fracture. He was neurovascularly intact, closed reduced, put into a sugar tongue splint. The 6-year-old male status post fall with his left distal radius buccal fracture. He was neurovascularly intact, closed reduced, and placed into a sugar tongue splint. So a 93-year-old female status post fall with a right distal radius fracture. She was neurovascularly intact, closed reduced, and placed into a sugar tongue splint.
Do you close reduce buccal fractures, or are you just saying that because you say that on all of them?
No, I actually pushed him back a little bit. He was a little bit volar, and then I.
Is it necessary? I mean, a buccal fracture goes through one cortex, really, and
No, I guess it was not necessary.
do you medicate these kids?
This kid did get a little intranasal fentanyl because he was painful.
Yeah, I was going to ask if he liked what you did to him.
I think the point is in a young, how old's a kid?
6.
I mean, it's going to remodel. You know, it's almost non-displaced. And a buccal fracture, I think just put him in a splint is what, you know, in most cases, that's all you need to do.
This is a 7-year-old female who fell during an aerial exercise and suffered a right both bone forearm fracture. She was closed reduced and placed into a sugar tongue splint. This was a 76-year-old female who stuck her hand into a blender that was on and suffered this left index finger. It was an open P3 fracture. She was neurovascularly intact. The lacerations were proximal to the nail bed. There was no nail bed injury. So she was sutured. She did receive a dose of Ancef and tetanus, and then was made non-weight bearing, and we'll follow up in a week. The 23-year-old male status post fight with this right 4th metacarpal head and neck fracture and a 5th metacarpal base fracture. He also suffered a bite to his left ear, which he was given unison and discharge on Metin for that. Otherwise, his finger cascade was in correct anatomic alignment. He was neurovascularly intact, closed reduced in this ulnar gutter. and an intrinsic plus, and he would follow up.
Was the blender laceration dorsal or volar?
It was circumferential. There were some lacerations kind of circumferentially around it, proximal to the nail bed.
So if it's proximal to the nail bed, what other structure did it lacerate, even though the fracture was in the midshaft of the
You'd be concerned about a flexor or extensor tendon injury, which these are all mostly basically just superficial lacerations that were repaired.
Okay.
On this one here, what did you close reduce when you talk about the fourth and fifth metacarpal?
I guess it was less of a reduction, more of just a splinting.
Yeah, I think that's appropriate.
The 67-year-old male status post fall with a left radial head fracture. This is a Mason 1. They were nervously intact with no block to chronosupination. They were stable in varus and valgus. They were made non-weight bearing and placed into a sling. It's a 21-year-old male who took a pallet jack to the side of his leg and was found to have this left Weber deep fibula fracture that was stress negative. He was neurovascularly intact. He was given a cam boot and made weight bearing as tolerated. This is a 46-year-old male who fell off of his bicycle with a left Weber B fibula fracture. As well, it was stress negative. Per his preference, he was placed into a posterior splint and made non-weight bearing. Because of the splint, he was also given aspirin BID. This is a 36-year-old male status post fall from a loading dock with a right great toe proximal phalanx fracture. He was nervously intact. He was buddy taped, made weight bearing as tolerated, and given a hard sole shoe. And then this is a 74-year-old lady status post fall during transfer. Of note, she's non-ambulatory for the last 3 years and extremely cachectic. Otherwise, she was neurovascularly intact. She would be not weight bearing as tolerated. So she was just advised to do PT and was given Dvt Prophylaxis.
I think it's a good idea that you put the ankle fracture with the splint on it on Dvt Prophylaxis. What about the patient that you put into the cam walker boot and made weight bear as tolerated?
He did not receive any Dvt Prophylaxis.
Is that because he's weight bear as tolerated, or?
Yeah.
Is there any evidence to support that one way or the other?
Not that I know of specifically. In general, I guess I've always just felt more comfortable with people who are going to be non-weight bearing for any prolonged period of time.
I don't know that it's, I'm asking because I don't know. I mean, it sounds reasonable. I just, people can get catastrophic Dvt PEs, with or without prophylaxis. So you just wondering.
I think a lot of it is done for medical legal purposes, truthfully, right? You worry about it. And if they do develop a PE, I had a guy that I treated with a fifth metatarsal fracture in a boot, and it was a cam walker boot, so he could take it off every once in a while for motion. And he had a near fatal PE, and I was not prophylaxing. So that was a long time ago. But I'm always, whenever I immobilize somebody from the knee down, I put them on aspirin for Dvt prophylaxis as a routine
How long do you do that for?
until they're walking on it.
With
We had
the ankles and lower extremity fracture, there is not a consensus or recommendations for DVT prophylaxis. Doesn't mean they recommend against it. The one thing you do have to ask them about is history of prior DVTs, PEs, or like hypercoagulability history, and in those cases, it's again not a clear recommendation, but it's more often than not suggested that you might want to consider using your clinical judgment to start them on anticoagulation. So these ankle fractures, I could ask them for that had had a PE, a strong family history of hypercoagulable disorders, any blood clots, if they're smoker or if they're on oral contraceptives, you might lean more towards giving them something, at least aspirin.
Serge, what if you non-opt an Achilles tendon, treated in a cast? You put them on Dvt prophylaxis or not?
I don't know about Achilles tendon, the ones like lower extremity fractures. I mean, I guess you could transfer that if, depending on the weight bearing status, that as all these, the ankle fractures, distal tibia, foot fractures, that's what the recommendations that at least that I know of. I'm not sure specifically of Achilles or like soft tissue reconstruction, but I guess the reasoning is they'll be if they're non-weight bearing, I guess the same thing applies.
This is a 7-year-old male, status post fall from a trampoline with a right infibullar shaft fractures, neurovascularly intact, close reduced, and placed into a long leg 5-valve cast. This is a 36-year-old male, status post punch against a pole with a left 5th metacarpal shaft fracture. He was neurovascularly intact, no rotational deformity, placed into an ulnar gutter splint. It's a 72-year-old female, status post unrestrained backseat passenger. She was in a low-speed MVC. She has this right distal radius fracture. She was neurovascularly intact, close reduced, and placed into a sugar tongue splint. An 87-year-old female, status post fall with a right proximal humerus fracture. She was neurovascularly intact, including the axillary nerve, made non-weight bearing in a sling. This is a 54-year-old female, status post fall from a mountain bike, a right medial clavicle fracture. Obtained CT scan. Just showing the medial clavicle fracture. She was made non-weight bearing in a sling.
Was CT scan ordered by trauma?
It was ordered by the ED. This is an 84-year-old female, status post fall with a right hip intertrochanteric fracture. She was neurovascularly intact, medically optimized, and taken to the OR for a right hip intramedullary nail. An 87-year-old female, status post fall with a left hip intertrochanteric fracture. The initial radiology reads on the X-ray were read as negative. Even though there is a fracture line there, so ED ordered a CT scan that again showed this intertro fracture undisplaced. So she was admitted to medicine, optimized, and taken for a left hip intramedullary nail.
Jeremy, what can you accept for the 5th metacarpal fracture that you showed?
You can accept 40 degrees, up to 40 degrees of angulation for that.
But was that a neck or a shaft fracture that you showed?
That was a shaft.
So is it 40 degrees for the neck or for the shaft?
I thought it was 40 degrees for the shaft. It's neck.
So it's 20 degrees for the shaft. And then obviously if there's a rotational deformity.
Gotcha. My apologies.
So the farther up the shaft the fracture is, for any certain amount of angulation, the more the metacarpal head is going to drop down. So if you fracture right below the head and it's 30 degrees, you're going to have less millimeters of volar translation than if it's farther up the shaft. So you're trying to minimize the amount of deformity of the rest of the finger. So that's a good reason, or a good way to think about it if you ever forget.
Gotcha. Thanks.
Good morning. First patient is a 67-year-old female presenting status post straddle fall with a right proximal humerus fracture. Patient has significant comorbidities and will be treated non-operatively at this time. We'll follow up with an outpatient for possible surgical planning. Next patient is a 78-year-old female presenting also status post straddle fall with a right proximal humerus fracture. CTs were obtained to further characterize the fracture pattern. Patient was neurovascularly intact on presentation and was taken to the operating room for reverse total shoulder arthroplasty. Next patient is a 7-year-old female presenting status post fall with a right distal radius fracture. Patient was neurovascularly intact and was initially closed reduced and trialed in non-operative management. The patient did follow up in the office and was placed in a cast at that time. It was shown that she had loss of reduction on this presentation, was taken to the operating room for a right distal radius open reduction internal fixation.
What was wrong with you over-reduced it the first time, and when you had it in the cast, it now has 15 degrees of volar tilt. What's wrong with that?
So, I mean, this was an intra-articular fracture. There's a huge volar shear component. I mean, if you look at the carpus, I mean, she's pretty dorsally angulated, and
what's dorsally angulated?
Well, her carpus is.
She's about 9 millimeters ulnar positive too. So I'm not sure I'd accept that.
I was asking him what the problem was, but that's okay. Ryan, you want to answer? Good. Okay. So
Yeah.
Do you have an X-ray of the other side?
We did not get an X-ray of the other side.
So there's nothing wrong with the volar tilt. The question is your DRUJ acceptable?
Yeah, I mean, as Dr. Coyle was mentioning, she did have positive ulnar variance. So, and she's, even though, she was 7 years old, she was pretty active and healthy, and, wanted a better functional outcome.
Well, I don't know that, if the difference from the other side is significant, then maybe that's the case. But even though it's short, and it is very short, that's the main problem here. There's certainly enough literature out there in a 7-year-old that the results are fairly similar. But you can make a much better case to show that the other side is ulnar neutral, because that's at least 5 millimeters or more, maybe a centimeter of shortening. And I think that's the biggest problem here. Not the tilt. It's not tilted dorsally at all here.
Yeah, sorry, I think what I meant to say was, even though she was, she did have a volar tilt, the carpus was extended. So, I mean, I think her deformity may be even more exaggerated if, she wasn't extended at the carpus.
Dan, what about the sagittal alignment from a translational perspective, not angulation?
So yeah, the carpus is translated volarly.
Does that matter?
Yes.
All right, and how do you measure that?
I don't know exactly how I would measure that, but if I was to attempt to measure that, I would draw a line going through the radial shaft and try to.
I will look up, there's a paper by Margaret McQueen that describes it, how to measure it, and the importance of sagittal alignment.
Okay, thank you.
With the carpus that far volar, what do you think is going to happen to that fracture fragment that's also volar if you were to treat it non-operatively?
Yeah, it'll continue to displace. Next patient is a 58-year-old male that was involved in an altercation, presented with a right distal radius fracture. Patient was initially closed reduced, and CT was obtained to further characterize the fracture pattern. Patient followed up in the clinic and was noted to have, again, a loss of reduction. Patient was taken to the operating room for open reduction and internal fixation.
How many weeks out is that?
This was about 3 weeks, or
So-
sorry, 2 weeks after the injury.
So what are the problems with the reduction before you were operated? What didn't you like?
At the initial reduction,
Well, your plain x-rays, what didn't you like about the x-rays that made you want to do surgery on this case?
so I mean, there was pretty significant loss of reduction. This is the original reduction film, and then when we saw him again in the clinic, I mean, he had fallen off dorsally, had lost a lot of his radial height and inclination as well.
So it's short. You're unhappy about the fact that it's short.
as well as the inclination.
Okay.
Next patient is a 42-year-old male that was sleepwalking and got into some altercation while sleepwalking, presented with right ring finger and small finger metacarpal fracture. Patient was taken to the operating room for open reduction and internal fixation. Next patient is a
What made you choose that type of fixation?
So, we chose to go with this type of fixation just given the fact that he had, multiple metacarpal fractures. He had pretty significant, it was a transverse fracture. So, our other options may not have been as ideal. We can't really do like an intrafragmentary screw for the ring finger metacarpal. He also had, pretty significant intra-articular involvement of the small finger metacarpal. We thought this would give him a more stable construct. He's a young guy, he's very active, so we wanted to give him more stable fixation.
So you're saying the little finger was intra-articular?
Yes. Next patient is a 42-year-old male presenting after a table saw injury with this left index finger P1 fracture. Patient was taken to the operating room for wound exploration, irrigation, debridement, and percutaneous pinning. Next patient is a 56-year-old female presenting after a fall with this left small finger P1 fracture. Patient was taken to the operating room for closed reduction, percutaneous pinning.
Can I just mention one other thing going back to the other case? What you did looks good, but the other option is closed reduction and percutaneous pinning. In case you wanted to, your little finger was basically non-displaced, and the ring finger was 100% displaced, but should have been relatively easy to reduce if it was early. And a simple longitudinal K-wire in a transverse fracture does well, as does percutaneous K-wires for the base of the fifth finger in an acute injury. I'm just making sure you are aware that both options are reasonable.
So how would you neutralize the proximal displacement of the fifth shaft? Because pinning is always an option with these fractures, but I would think that you would want to neutralize that pull somehow, and then you're talking about pinning to a fractured fourth metacarpal, or trying to get an oblique wire into the carpus to distract it.
Well, first, I don't see clearly the intra-articular portion, which means it's probably non-displaced. So
Just show the injury films.
The fourth is 100% displaced. The little finger, on my views, looks, I would have put that in a splint had they come to the office. The CMC joint is perfect or close to it. But if you're doing the fourth, it makes sense to if there is an intra-articular fracture of pinning that base to the carpus. I mean, I would probably put a pin in there. The shaft is non-displaced, and if you want, you could put a pin down the shaft. I don't see displacement there. To me, the key here is if the ring finger metacarpal wasn't displaced 100%, you wouldn't even be operating on this.
I see the point with the, trying to get the length out of the fifth metacarpal. I think that since the fourth metacarpal isn't too comminuted, once you reduce that and pin it, then it's probably going to be more stable to, get a fifth to fourth pin in to keep that fifth distracted a little bit. I think either way would have worked.
Yeah, I'm just pointing out it's another option, a simpler option, if you're by yourself in the middle of the night.
Does that hardware have to come out on the fifth metacarpal?
Yeah, the hardware would likely have to come out. This hardware will limit his motion at that joint. So
This hardware will break if you leave it in.
Right. So now you have to go back, and you can't just take that out percutaneously, right? You have to make an incision.
I think there are a lot of ways to treat this one, but one advantage that we haven't mentioned by doing this is you get, stable fixation when you leave the operating room, and you can get this guy into immediate hand therapy and motion.
Yeah, but no matter how you treat this, he just needs a wrist splint. You can move his hand right away, no matter how you treat this. You don't have to,
just in my experience, sometimes when you have a bunch of pins sticking out, people are a little apprehensive to move their fingers.
Our next patient is a 98-year-old female presenting after a ground level fall with a left LC1 pelvis fracture. Patient was made a protected weight bearing with a walker, placed on Dvt Prophylaxis. Next patient is a 13-year-old male that was supposed to fall while skateboarding with a right femoral neck fracture that was non-displaced. Patient was taken to the operating room for cannulated screw fixation. Next patient is a 68-year-old female presenting status post ground level fall.
For the previous case, does the spread matter as much as it does in an adult?
So I mean, I think the spread definitely does still matter even in a 13-year-old. Ideally, I think the spread could have been more appropriate. We could have ideally, you want to have an inverted triangle. The study by Booth and 98 kind of shows we want 3 screws with adequate spread, with 1 screw kind of resting on the inferior calcar, and having 2 other screws in an inverted triangle orientation to provide most optimal fixation biomechanically. I think given the fact that this was non-displaced, we'll still have a good outcome, but we could have definitely had a more ideal screw distribution.
Did something prevent you from putting it in a different position? I'm assuming you'd use guide wires first, right?
Yeah, we use guide wires first. So intraoperatively, I did note the trajectory that we were taking. I tried to discuss with the attending, changing the trajectory of the screws and the orientation, but the attending felt that this construct would be stable. Next patient is a 68-year-old female presenting status post ground level fall with a right femoral neck fracture. The patient was taken to the operating room for a right total hip arthroplasty. Our next patient is a 60-year-old female that presented after a trip, not actually a full ground level fall. This left tibial plateau fracture. CTs were obtained to further characterize the fracture pattern. And given the patient's comorbidities, patient was treated non-operatively with a neomobilizer, a non-weight bearing. Thank you.
What were the comorbidities?
Yeah, so patient had pretty significant renal comorbidities. She had diabetes and CKD, was about to start hemodialysis. So just given all the comorbidities, and she, in terms of activity, not the most active person, but just kind of community ambulator, decided to just try non-operative management.
How do you think she'll do non-operatively?
I mean, she's definitely gonna, I'll put the x-rays back up. She's definitely going to, develop some arthritis. She already has some arthritis medially as well. So she likely will eventually have some stiffness and maybe some pain long-term. But I think this is probably heading towards, like a total knee or other fixation option down in the future.
What if it was her medial plateau instead of her lateral plateau?
So I believe medial plateau would probably be more inclined to fix acutely.
When you examined, did she have a lot of valgus apparent laxity?
Yeah, so I tried to assess, if she had valgus laxity, but she was pretty limited by her pain. So I wasn't able to get a good examination at the time. I would definitely re-examine her once kind of her swelling and her pain has improved.
Because that can be a good indicator of how a lateral tibial plateau is going to do, right? If she doesn't have a lot of, and it's not laxity, because she doesn't have an MCL injury, most likely, it's apparent laxity because either the condyle falls into the defect or it does. If it doesn't fall into the defect, maybe because of the integrity of the lateral meniscus or because of the location of the fracture in the anterior posterior plane, she might do really well treated non-operatively and not have any worse symptoms than she had before the fall because she's already got medial compartment arthritis to begin with. So your exam can help you, determine whether you think they might, she's got comorbidities. You might want to operate, just wait till she needs a total knee and do it. But if she doesn't have, again, if she doesn't have it, she'll probably do better than you think, even though your x-rays look bad.
Thank you.
When we're talking about these displaced wrist fractures in old people, I mean, most most things are relative indications. I mean, there are very few absolute indications to operate on these. But you need to, have a discussion with these people about what's going to happen to them. And if you see a visibly deformed wrist, such that, that X-ray that we showed before, the patient needs to know that they're going to have significant limitations in their motion, and whether that's functional or not, that's patient specific. So, 70 means a lot of different things. We saw a 74-year-old bedbound cachectic person, and then we see a 70-year-old, independent, person who works and, runs their own house. So these are all things, it's not just, X-ray, fix it, don't fix it. These are, especially as you get up 65 plus, these are very important discussions that you have with the patient. And that's why, these are, these are a little bit complicated to talk about, if you're just looking at an X-ray versus, treating the patient.
Good morning. First, we have a right hand dominant 10-year-old male, as was fall for the month of August with its right. This is both bone forearm fracture. We have disclosed reduced, goes into a sugar tongue splint, followed up in the office. Next, we have a 49-year-old female, so that was a ground level fall with the left ankle, final ankle equivalent on stress. She disclosed reduce, goes into a short area splint. She'll follow up in the office to discuss surgical management of this injury. Thank you.
Good morning. First patient's a 4-year-old male with autism who tripped in a rabbit hole, sustained what looked like a isolated left coronoid fracture. He did have some swelling and pain there, although he had full range of motion, and he was placed into a long arm cast. There's no post cast films. This is an 8-year-old female, Sassos fall with a left both bone forearm fracture. She was closed reduced and placed into a sugar tongue splint. There's a 12-year-old male Sassos fall with a non-displaced left Salter has 2 distal radius fracture. It's placed into a sugar tongue splint. There's a 91-year-old female with severe dementia who sustained a ground level fall and has this right proximal humerus fracture. She was given a sling and made non-weight bearing. There's a 61-year-old male who fell while exercising here, just visiting for a wedding, and sustained this left Montasia fracture. He was initially closed reduced in the ER and then taken the following day for an olecranon ORIF.
What type of Montasia is it?
Sorry?
What type was it?
So it went posterolateral. So it would be a type 2.
Was there a fracture of the, like on the right one, looks like the radial head might be fractured.
Yeah, we also thought that looking at it, but on the fluoros in the OR, we didn't really see anything obvious. There definitely could have been.
Is there a floor or post-op film that shows the radial head's reduced?
Yeah.
Which one?
All these, and
what is a reduced radiocapitellar joint supposed to look like?
I'm not sure I understand.
On a perfect lateral of the elbow, where does the radial head sit compared to the capitellum?
Centered on it.
Yeah, it pretty much lines up. Is there one showing? Well, the right one is not a perfect lateral because it's kind of probably a little oblique.
Yeah, I mean,
But-
the fluoros that we're seeing do not show it perfectly, but prior to the final fluoros, we had shots before the hardware was finalized.
Because in that right one, that radial head is almost below the capitellum.
Yeah, it does look that way on this shot, yes.
Do you have
A
films
cou-
in the,
I was just going to make a comment there in terms of your distal fixation. To me, it looks like you only have one true screw that's distal to the fracture site.
Yeah. So it was a surgeon's preference not to extend the exposure distally because the plates only come by 2 screws at a time, and he didn't feel that an additional 2 screws was necessary for this. There's kind of like a coronal split in this fracture, so even though there's only 2 screws past the fracture site, it was felt to be stable with the lag screw that was there.
Yeah, I think in my experience, the longer the ulnar plate, the better. And also, this is one I might have recommended getting a preoperative CAT scan, because I agree with Serge that I think you have an intra-articular radial head fracture as well.
Yeah, I think
and it's probably fractured superior aspect of the radial head, which will probably make it more unstable. So you want to make sure, one, you have a good lateral, which I don't see one there necessarily, and then you want to make sure is reduced in 90 extension, flexion, whatever it is, because right now you don't have imaging that shows that the radial head is actually reduced. So if it does dislocate, or in the office you see it's still not where it needs to be, that means you left the OR with, you can't prove that it was reduced.
What's that little implant going up into the tip of the coronoid?
that's
our lag screw.
That's our lag screw going through that coronal slit.
Is there where did you guys do this case? I'm just curious.
I'm sorry, where did we do it?
Yeah.
Here at Robert Wood.
There's more than one implant available also, if that was a concern. I think in the same tray, by the way.
Okay.
We asked that going longer.
Is there any ligament damage that you guys saw?
No, after the plate was on, everything was stable and he had 4 range of motion. This is an 18-year-old male sustained a fall off his skateboard, the left distal radius fracture. He was closed reduced and placed into a sugar tongue splint. This is a 59-year-old female status fall with a left distal radius fracture. She was closed reduced and placed into a sugar tongue splint. Is a 53-year-old male sustained a fall from a ladder with a right distal radius fracture. He was closed reduced and placed into a sugar tongue splint. Is a 50-year-old male fell off a bicycle with a left small finger middle phalanx pilon fracture and a ring finger proximal phalanx fracture. He underwent a CAT scan to further delineate the fracture patterns. He was then closed reduced, placed into an extension blocking splint on the small finger and buddy taped, and left to AMA prior to any further discussion.
If he stayed, would you have done anything differently?
Yeah, I think that the small finger would be operative for me.
And what's
What
your
would you do?
operative procedure of choice?
I'm sorry.
What would you do?
What would be
What
your
operating-
operation?
Sorry, I couldn't catch
What would
that.
you do?
We want to know what you would do.
So I think you have a couple options here. It seems to me like the main fracture line is coronal. I think that you could be able to do headless compression screws, but if it's too unstable or too comminuted, you could definitely consider a dynamic X fix.
I think I would favor the second one. I think headless compression screws are very unlikely to hold that. Maybe regular screws, like one screw to augment it, but you need to offload that axial pressure on the joint. So I think that dynamic X fix would be a better choice, but you're going to really have to go distal. and I don't know how dynamic it's going to be if you go that distal.
I think he made the right choice leaving AMA and getting away from you. I think that was a good choice on his part. Good job.
Agreed, yeah. This is a 24-year-old female, status host, crush injury with a weight at the gym, and sustained this open left ring finger distal phalanx fracture with a nail bed injury. She had an IND and a nail bed repair. This is a 55-year-old male, status host fall with a left calcaneus fracture, also with a right non-displaced posterior malfracture that was only seen on this CAT scan. He was placed into a bulky dressing on the left side and an ASO brace on the right side. And so follow-up is an outpatient and possibly surgical planning for the left side.
What kind of surgery are you doing for him?
I think that it's pretty comminuted.
Classify it.
So it would be a Sanders 3.
I would 3 going on 4 probably.
Okay, 3 to 4.
So what are the treatments?
So, you could attempt an ORIF. It would be challenging. Definitely need some bone graft in there. But he might be looking at a TTC fusion.
What's a TTC fusion?
Sorry, not TTC. It's like a hindfoot fusion. Talocalcaneal fusion. You don't need to fuse the ankle.
What? Be more specific. What joint are you fusing?
The subtalar joint.
Okay. Talocalcaneal, because there's more than one talocalcaneal articulation, but the subtalar. Which ones is it recommended to do the fusion versus ORIF?
Which joint?
Which classification?
4.
Okay.
This is a 69-year-old male after an NBC sustains a number of orthopedic injuries, including a right ankle bimalleolar fracture, a right coracoid fracture, a left medial clavicle fracture, a left LCO and pelvis fracture, and a right side sacral fracture, in addition to multiple non-orthopedic injuries, including sternum, ribs, a pneumothorax, and a retroperitoneal hematoma that required an XLAP. After he was medically stabilized, he was closed reduced and placed into a short AO splint for the ankle, and then taken for a right ankle ORIF. And these are his other injuries, showing the right coracoid and left medial clavicle. It's made weight bearing as tolerated on all of his extremities except for the right lower. There's a 20-year-old male who fell playing basketball and sustained this left fourth metatarsal head fracture dislocation. He was closed reduced and placed into a posterior splint.
Good morning. First patient is a 54-year-old male, sat close similar to collision, presented with C11, 3-column flexion distraction spine injury. Have a burst compression fracture, extended posteriorly. He was neurovascularly intact. MRIs were obtained. showing some extension of the posterior ligamentous complex. And he was taken the following day for a T9 to L1 posterior spinal fusion. That's all. Thank you. Morning. First case is 89-year-old female, status was fall, right hip intertrochanteric fracture, was medically optimized, taking the OR for a right hip by a nail. It's a 92-year-old female, status was fall, the left hip intertrochanteric fracture. Of note, she has multiple chronic pelvic fractures with frequent falls. These are largely unchanged from X-rays done about 6 months ago. She was medically optimized and taking the OR for a left hip IM nail. Morning. First patient is a 48-year-old male who had a slip and fall with his left metatarsal fracture and ipsilateral non-displaced distal radius fracture. Initially closed reduced in the ER. Non-displaced distal radius fracture was noted at that time. He was taken for a left olecranon ORAF and splinting of the distal radius.
Is that plate different than the one that was used before? I mean, other than
yes,
company?
this was same company. The last one, this was the VA locking, as opposed to the other one, which is just standard locking.
Which set did it come in?
What was that?
Which tray did it come in?
This was the VA locking tray for Lecrinon, and the other one was just a standard locking tray.
Did you need to use that plate? Could you just use the basic plate, a 3-5?
We probably could have used the basic one. This was the attending preference to use the VA locking plate for this case. We could have gotten away with the other one. We didn't really use the VA function. Next is a 76-year-old female who's sustained a trip and fall with a left femoral neck fracture. Taking the OR for a left hip hemiarthroplasty. Next is a 79-year-old gentleman with history of AFib, CAD, a ejection fraction in the low 30s, as well as pulmonary fibrosis and history of lung cancer. Was optimized to the OR and taken for a left hip hemiarthroplasty, or sorry, right hip hemiarthroplasty. Next is a 26-year-old gentleman, suspect MBC with a right femoral shaft fracture. It's taken for a right femur IM nail, so I did not include the CAT scan showing there was no ipsilateral femoral neck fracture. Next is a 49-year-old gentleman, suspect motorcycle collision, the left tibial plateau fracture. CAT scan was initially obtained, better delineate the fracture pattern. He was provisionally X-fixed and taken 2 weeks later for an ORIF. Next is a 19-year-old female who's riding one of the electric scooters around New Brunswick, sustained this right trimal ankle fracture. Initially closed reduced, placed in a short area splint, and taken for a right ankle ORIF.
Did you get a CAT scan?
We did not get a CAT scan of this one.
Does it look like a typical trimalleolar ankle fracture in your injury films?
It does not. In the intra-op, that posterior mal was actually attached to the medial mal piece. It was kind of a coronal split piece, all one fragment. That's why we only used this one lag screw. We did stress it in the OR, stress negative. Oh, it was stable stress.
So that tip of the medial mal, is that not a separate piece? Because it looks like on the middle, second from the left, and the floor on the right, it looks like it's not reduced right now.
Yeah, it was slightly, it kind of malreduced slightly when we put the screw in, but it was acting as one full piece along with the posterior mal coronal shear piece.
So it's coronal, and your screw is going from medial to lateral.
It was, I guess it was more oblique. It did wrap around to include the other piece right there.
It's hard to tell because the fibular plate is on, but because you can't tell if the posterior mal is reduced.
Yeah.
Did you put the plate on first and then do the medial mal, or and or posterior? What was that?
We did. We put the lateral mal, the fibular plate on first.
So how do you know it's reduced?
Yes,
It goes right through where the fracture line would be, so you can't tell.
Yeah.
He's what, 19?
She's 19, yes.
I would get a CAT scan beforehand. If it does, it looks a little funky or atypical, especially in a 19-year-old. You might want to know a little better and not guess in the operating room.
Agreed. Next is a 54-year-old female who sustained a fall down several steps with this pilon variant / left distal tibia fracture. CAT scan was obtained initially in the ER. She does not go really intra-articular at all. She was initially or provisionally placed in an external fixator and taken in delayed fashion about 14 days later for an ankle ORF. And that was it.
Your office.